Hello and welcome to Noon Conference hosted by Medality. Noon Conference connects the global radiology community through free, live educational webinars that are accessible for all and is an opportunity to learn alongside top radiologists from around the world. You can access the recording of today's conference and previous Noon conferences by creating a free account. Today, we are honored to welcome Dr. John Jacobson for a lecture entitled Ultrasound of Peripheral Nerve Entrapment. Dr. Jacobson is a board-certified musculoskeletal radiologist and currently works at Lenox Hill Radiology in New York City and University of California, San Diego. His academic achievements include over 260 peer-reviewed publications and many invited national and international lectures and workshops. Dr. Jacobson has been a visiting professor on over 50 occasions, is president of the Society of Skeletal Radiology, and has received numerous teaching and mentoring awards, including the 2023 Distinguished Educator Award. He is also the author of the textbook Fundamentals of Musculoskeletal Ultrasound, and we are honored to have him here with us today. At the end of the lecture, please join Dr. Jacobson in a Q&A session where he will address questions you may have on today's topic. Please remember to use the Q&A feature to submit your questions so we can get to as many as we can before our time is up. With that, we are ready to begin today's lecture. Dr. Jacobson, please take it from here.
Okay, great. So I'll be talking about ultrasound of peripheral nerve entrapment. As an aside, the QR code here will get you to a PDF of my syllabus of this lecture. I'll also have the QR code at the very end if you can't get to your phone quick enough. These are my disclosures listed here. They are really not relevant to the talk, but they are listed nonetheless. So first, a few introductory comments about ultrasound of peripheral nerves. They're best identified in short axis, because in short axis, that's when they appear like this honeycomb appearance, where you can see the individual hypoechoic nerve fascicles and the echogenic connective tissue around the nerve fascicles. This is the median nerve in the carpal tunnel. Obviously, as you scan a nerve more peripherally, as the fascicles will arborize and move away from the trunk, it will get smaller and smaller. But when you look at a nerve trunk, it's this honeycomb appearance that is characteristic. Note here I'm toggling the transducer to help differentiate the adjacent tendons, which are hyperechoic, demonstrating anisotropy, whereas the nerve trunks themselves, only the connective tissue will demonstrate anisotropy, so there's much less anisotropy. You can see the nerves in long axis as well, but the short axis is really how you identify the nerve and how you can efficiently look at a nerve throughout the entire extremity. Another comment I want to make is about nerve compression. That's going to be really what I'm emphasizing in this lecture on entrapment neuropathies. What's been shown in the animal model is that when you compress a nerve, what happens is there's ischemia, and the first pathologic change is edema. After that, you have demyelination and then axonal damage. The point here is that inflammation is not present with nerve compression. So the term neuritis is really a misnomer, and using that term is actually not very helpful because it could trigger the clinician to think that injecting steroids can cure the process when really there is no inflammatory component at all to compressive neuropathies. What do we look for by imaging? Ultrasound and MR imaging, what we're looking for is edema. Again, that's the first stage of any kind of entrapment, edema of the nerve. And also you'll see enlargement typically in many of these locations where I'll be talking about nerve entrapment. And the swelling or enlargement will be at and proximal to the entrapment site, a process that's called axonal damming. And then the edema and the enlargement can persist more distally, but it's most pronounced proximal to the enclosed fibrosis canal or entrapment site. Now, when looking at peripheral nerves by ultrasound or MR, we always have to be aware of the end organ, looking at the muscle, because this is a very helpful point to determine the nerve distribution that is abnormal, but also it tells you the severity of what's happening. So I want to talk about this by ultrasound. What we're looking at here is an example of atrophy in the upper image. So I want to mention that edema appears hyperechoic, and fatty degeneration or infiltration also appears hyperechoic. So I want to take a moment to talk about the physics of why both of these different processes produce the same finding. So if we talk about, let's talk about fatty degeneration first. We know pure fat is nearly anechoic. It's very hypoechoic. It's not really shown in this image, but this hypoechoic area here in the subcutaneous area, that is pure fat. You might wonder, why is hypoechoic muscle and hypoechoic fat, when you mix this together, why does the muscle appear hyperechoic? Well, it comes down to the physics of the image, because ultrasound, we're essentially looking at reflections of interfaces. What determines the reflectivity is the speed of sound or impedance of the tissues across that interface. So even though pure muscle is hypoechoic, pure fat is hypoechoic, their speed of sound is different. So when they're interdigitated, it produces reflections because of those differences in speed of sound. The same thing happens with edema. We know fluid is anechoic by ultrasound, but if you mix anechoic fluid with hypoechoic muscle, the speed of sound is different, producing reflectivity. Incidentally, muscle fibrosis also appears echogenic, and even muscle inflammation, something I'm not talking about today, will also appear hyperechoic. The last point, if you're looking for subtle increased echogenicity of muscle, it's imperative to compare to the other side. I've seen cases where when you put the transducer on the muscle, the image looks really bright. You turn the gain down so it starts to look like normal muscle. What you really want to do is look at the contralateral asymptomatic side, set the gain appropriately based on the background light of the room, and then go to the symptomatic site. All right, so what I'm going to do in this lecture is run through the peripheral nerves, starting with the upper extremity, covering the entrapment syndromes. First, beginning with carpal tunnel syndrome. Of course, the most common entrapment neuropathy of the upper extremity. Now, there are a bunch of numbers that are listed, which are here on the slide, to indicate if you needed to look at the size or the area to be more exact with the diagnosis, you can do so. In fact, when I think about ultrasound of peripheral nerve entrapment of the extremities, this is probably the only nerve where I will actually measure the area because of litigation issues. And also, many insurance companies need more strict criteria met to approve various treatments for carpal tunnel syndrome. Anyways, these are the numbers that you may apply. Now, here's what it would look like. The peripheral nerve will be enlarged and hypoechoic. Here we see in cross-section, the nerve indeed is enlarged, and the echogenic connective tissue layers are really more hypoechoic. So globally, the entire median nerve is hypoechoic. In long axis distals on the right, we can use the bone landmark for orientation. Here's radius, lunate, and capitate. We can see the enlarged hypoechoic nerve going underneath the transcarpal ligament or retinaculum. Some people have coined the term the notch sign. It's basically showing a difference in thickness related to compression. Note the adjacent flexor tendons here, which are more hyperechoic and fibrillar or fiber-like. Now, if you are to measure the area of a nerve, it's done on short axis. You want to toggle the transducer to define the epineurium, which is the white layer surrounding it. You want to find the area of maximum enlargement, and using circumferential trace, don't try to put an ellipse to it or X times Y. That is inaccurate. You want to trace on the inside of the epineurium for the most accurate assessment or measurement of the area of the nerve. Now, one problem about using just a single number to indicate what is abnormal, meaning a number that you can apply to everyone, the problem is someone who's 5 foot versus 6'8", their nerves are intrinsically different size. So this is the criterion I use to diagnose carpal tunnel syndrome when I'm measuring nerve enlargement. And you can see the numbers here are really quite good. What this paper describes is you measure the nerve area at its maximal enlargement, and then you compare to the size more proximal at the level of the pronator quadratus. If that area increases by 2 millimeters square or more, that's when you get 99% sensitivity, 100% specificity in the diagnosis of carpal tunnel syndrome. Here is another case of carpal tunnel syndrome showing nerve enlargement. Now, most of the time when we see carpal tunnel syndrome, there's really no, I guess, physical finding, meaning there's no ganglion cyst or there's no synovitis, usually in most cases. So here's an unusual case, a patient with rheumatoid arthritis. What we see here is synovitis around the flexor tendons associated with this carpal tunnel syndrome. Now, be aware, technically, this is not tenosynovitis. There's no tendon sheath here. This is actually the ulnar bursa that essentially functions like a tendon sheath. You can still call it tenosynovitis, although it's not completely accurate. It's really the ulnar bursa interdigitating between the flexor tendons within the carpal tunnel. As we leave carpal tunnel syndrome, remember you can have a bifid median nerve is a normal variant. Some people say up to 10% of the time. And indeed, those can be enlarged and hypoechoic with carpal tunnel syndrome. The criterion used here is 4 millimeters square if you add the numbers together compared to proximal measurement. And as an aside, you should not see flow on color or power Doppler imaging in a normal nerve. So that can be another indirect sign of carpal tunnel syndrome. Moving on to another entrapment syndrome of the median nerve, pronator teres syndrome. What this involves is the median nerve as it passes between the two heads of the pronator teres. This is really quite rare. This is the only case I've seen. And what we're looking at here is indeed nerve enlargement. Now, why I think we do not see this well at imaging is that unlike the carpal tunnel, where you have an enclosed fiber osseous canal creating this axonal damming and edema that's constant, this is more of a physiologic entrapment where the nerve is compressed but not continually, and that's why we don't get this dramatic enlargement and edema of the nerve proximal to the entrapment site. But this is, again, quite rare. Moving on to anterior interosseous nerve syndrome, there is problems when trying to make this diagnosis. And the reason is twofold. First of all, looking for the anterior interosseous nerve is challenging, even in normal people. If you put on the color Doppler imaging, it's usually sitting right next to this artery here. But why this makes this very difficult is the end organ, which are the muscles, which showing denervation, what that will do, it really obscures the deeper structures. It dampens the strength of the ultrasound beam. So what I find in trying to diagnose anterior interosseous nerve syndrome, I'm really relying on looking for the end organ or the denervation changes, also shown here on the MRI. Now, there is a clinical exam finding that can help you to indicate, yes, this really is a problem. If you have them make the OK sign, if they cannot make the OK sign, they are not OK. So that is the clue to the diagnosis. Moving on to the ulnar nerve, first at the wrist. In Guillaume's canal or the ulnar tunnel is where we're looking for the ulnar nerve being compressed. Now you can have an accessory abductor digitorum minimi in up to 24% of wrist. I think it's more about 20%, but this is what the literature says. That can cause compression. Uncommonly, you could have what's called hypothenar hammer syndrome, where the primary problem is ulnar nerve thrombosis, but you could have edema and swelling with mild secondary nerve compression. So here's an example of an accessory abductor digitorum minimi. What we're looking at here is the pisiform as my bone landmark. We know in the transverse plane between the ulnar artery and the pisiform is the ulnar nerve. The ulnar veins are collapsed. You should not see any muscle in this area, and this is the accessory muscle, most commonly going over the top of these structures, uncommonly interdigitating between the ulnar artery and nerve. But you can see here the hypoechoic muscle, the linear fiber adipose layers between the muscle, characteristic of normal muscle tissue. I've seen ganglion cysts here, uncommonly lipomas. It's not very common, but you can have masses in the area also causing compression. Now, here's an example of hypothenar hammer syndrome, historically described in Europe, where people are using their hand to shingle roofs. I don't recommend that. This is more people falling on their hand or people using racket sports. And what we see here is thrombosis in the ulnar artery and thrombus more distally. The point here is the edema and swelling related to the ulnar thrombosis. You could have some ulnar nerve symptoms, but not truly an entrapment neuropathy per se. And here's a companion case. This entrapment neuropathy is really between the hook of the hamate and the handlebars of a bicycle. So this has been called cyclist wrist, where having the hand or wrist resting on the bicycle handlebar will compress the nerve between the handlebar and the hook of the hamate, producing the ulnar nerve symptoms. Now moving on to the cubital tunnel syndrome, the second most common entrapment neuropathy of the upper extremity. Let's look at the anatomy. The true cubital tunnel is this canal here where the ulnar nerve passes underneath the arcuate ligament and between the two heads of the flexor carpi ulnaris. Now remember, what we're looking for here is edema and enlargement at and proximal to the entrapment site. So we tend to see this edema more proximal behind the medial epicondyle. So that's why I'll start imaging, look for the enlargement, and then look for the transition or compression of the nerve as we look distally within the true cubital tunnel. Here's an example where the nerve is markedly enlarged. You look here in long axis, the nerve getting larger and larger, edematous, and then compressed under the arcuate ligament. Now, there are numbers here, but I have to admit, I usually don't need to measure the area here. And the point here is when you're scanning a peripheral nerve, you need to scan the entire nerve. However, recognizing there are specific sites in the extremity prone to entrapment. And as you're scanning the nerve in short axis, again, that's how you identify the nerve should not enlarge. They should arborize and get smaller. So as you're scanning the nerve in short axis, as you approach a fibrosing canal like the cubital tunnel, the nerve will start to enlarge and get more hypoechoic. And then as you enter into the entrapment site, the nerve will get smaller. So just moving the transducer back and forth, even without measuring, usually I can subjectively know that there's going to be some entrapment neuropathy. The second thing is where the nerve is edematous and large, it is very sensitive to ultrasound pressure. So by pushing with the transducer, it will elicit symptoms. So you get that feedback as well. So usually I'm making up my diagnosis in short axis alone without any measurements. Of course, you can look in long axis to complement, which I'm showing here, and you can measure if you choose to do so, like I do in the carpal tunnel. Here's an example of an enconeus epicoclearis. When you look at the cubital tunnel region, here the MRI is turned upside down. With the elbow extended, you shouldn't see any muscle overlying the area of the ulnar nerve. And here, this is the abnormal situation. Remember not to call this a cyst or a mass, recognizing the hypoechoic muscle and the fibroadipose layers. Here is the ulnar nerve. So 2 points I want to make about this. First of all, it is very common to see edema of the ulnar nerve without enlargement in a normal situation, asymptomatic patients. And we see this on MRI as well. It's been shown that of all the nerves in the extremities, minimal edema on the ulnar nerve without enlargement is a common asymptomatic finding. And this can be explained if you think about the nerves in the extremities. The ulnar nerve is one nerve that really goes through a lot of flexion as you bend the elbow. So you're going 180, 270 degrees. This nerve is making a tremendous turn. And this is why, in theory, you can have asymptomatic edema of the ulnar nerve, but it should not be enlarged. The second point I want to make, you want to scan this area with the elbow in extension. And that is because when you flex the elbow, the triceps comes into view, and our accuracy in diagnosing this accessory muscle goes way down. So you want to start with the elbow extended or nearly fully extended, and then make sure that there's no muscle in this area to indicate this normal variant. Now, speaking of elbow flexion, when someone has ulnar nerve symptoms, we're also going to look dynamically and look for ulnar nerve dislocation. Now, this can happen in up to 20% of asymptomatic individuals, but nonetheless, we're going to look for this. You put the transducer on the medial epicondyle. As you flex the elbow, the ulnar nerve should stay behind the epicondyle. Here is the abnormal situation. Here it's coming with the top, snapping back. Don't put too much pressure with the transducer because you can inhibit the nerve from going back and forth. So obviously the nerve snapping in and out, that can cause some edema of the nerve and irritation. Also, having the nerve out of its normal protected area predisposes it to direct impact injuries. Now, when we're looking at the ulnar nerve for dislocation, we have to be aware of what's called snapping tricep syndrome. In this scenario, indeed, the ulnar nerve dislocates, but there's an additional finding. The medial head of the triceps shows subluxation. And I'll show you what this looks like. Anterior is on the left. I'm going to start the cine clip. Here's the medial epicondyle. And in neutral position, here is the ulnar nerve. Now I'm going to flex, and look what happens. Dislocated nerve, snapping of the triceps. And as we extend the elbow, we can see both of these coming back to their normal location. Why this is important to consider is clinically this may be difficult to pick up. So many times the ulnar nerve dislocation is easily felt clinically, but this can be problematic. There's one case that comes to mind of a violinist who went to surgery for ulnar nerve dislocation, didn't have imaging. After the nerve transposition, the patient still had symptoms. Patient came back for our imaging, and the patient had snapping triceps that was not anticipated, had to go back for a second surgery to debride the muscle. So it's important to consider this, where both of these structures are abnormally moving over the medial epicondyle. Okay, moving to the radial nerve and posterior interosseous nerve syndrome. When we follow the radial nerve between the brachialis and brachioradialis, it will divide into a superficial and deep branch. When the deep branch goes between the two layers of the supinator under an edge of connective tissue called the arcata frosch, that is where the entrapment occurs. The nerve looking for edema and enlargement at and proximal to the entrapment site. The deep branch will go into the supinator and exit as the posterior interosseous nerve in the dorsal part of the forearm. So it's interesting, many people will divide this into two subtypes of syndrome: supinator syndrome and radial tunnel syndrome. For supinator syndrome, that's when there are motor deficits, abnormal electrodiagnostic studies, and imaging will show nerve enlargement and edema, ultrasound and MR. This is what we typically see, where we see the normal nerve on this contralateral side. Here we see enlargement and edema as it goes at the edge of the arcata frosch between the two layers of the supinator. Now, radial tunnel syndrome is more problematic. Patients have pain, but there are no motor deficits, normal electrodiagnostic studies, and no nerve enlargement. However, we do see muscle denervation on MR. So that is why if I'm scanning for posterior interosseous nerve syndrome on ultrasound, if it's normal, I'll have them go to MR, knowing that it is more sensitive on MR to see this subtle muscle edema that could indicate radial tunnel syndrome. Moving on to Wartenberg syndrome, looking at the superficial sensory branch of the radial nerve toward the forearm and wrist. Now, we can easily find the superficial branch of the radial nerve as it courses over the first wrist compartment. Of course, this is where we look for de Quervain tenosynovitis. Here's the honeycomb or speckled appearance of the superficial branch of the radial nerve. This is not the site of Wartenberg syndrome, but I just wanted to highlight where you can identify the nerve easily. Where I tend to see problems here is a hematoma and compression due to venipuncture injury, etc. So this is more of a traumatic problem more than Wartenberg syndrome. But looking at Wartenberg syndrome, this is more proximal to the forearm, still the distal part. And what we're looking at is where the nerve comes out over the brachioradialis, under the eccentric carpi radialis. And when the hand is pronated, that's where the compression occurs. And here we can see the hallmark of an entrapment neuropathy or compression, which is edema and enlargement at the compression site. So sometimes finding the nerve at this location is challenging. That's why I started by saying where you could find the nerve more proximally, then you could move, more distally and then move proximal. You could always look at the elbow and then track it distally that way as well. But this is the finding that we see with Wartenberg syndrome. Finishing the upper extremity, looking at the suprascapular nerve, really related to a paralabral ganglion cyst. We use the term paralabral cyst to indicate that this is caused by a labral tear, where joint fluid will come out of the joint, usually labral detachment, producing the cyst. They can occur in the spinal glenoid notch, where you would have downstream atrophy of the infraspinatus, or you can have it at the suprascapular notch, affecting more proximally, therefore, the supraspinatus and infraspinatus. And here's the labrum, here's the glenoid, here's the humeral head. We're not that great in looking for labral tears with ultrasound, but nonetheless, if you see a multilocular cyst at the base of the labrum, look carefully for the labral tear, and usually you can suggest it at least. Here, incidentally, the infraspinatus muscle is edematous, showing increased echogenicity on ultrasound, therefore denervation changes. As you know, the earliest signs of denervation is edema, and then later on is where you see fatty infiltration or degeneration, and finally atrophy, where there's decreased size of the muscle. Now, when performing ultrasound for a paralabral cyst, we have to be aware of normal suprascapular vein dilatation or dilation. Here's the normal shoulder, looking at the infraspinatus muscle and tendon, humeral head, labrum, and the posterior glenoid. Here's where we're going to look for the suprascapular nerve. Now look what happens as we externally rotate. We see normal suprascapular vein dilation. So if I froze this image right here, this looks almost exactly like a paralabral cyst. Now, how you can differentiate this from a true cyst, don't rely on color Doppler tracing. The flow is so slow with this dilation that even the waveforms are negative. But the key is what I'm showing here. This is a transient finding, meaning when you internally rotate, it collapses. When you externally rotate, it dilates. You will not see that happening with a paralabral cyst. Those are somewhat tense, they're under pressure. The fluid is quite viscous. It's not going to fully collapse like this. That's how you make the distinction. Okay, moving on to the lower extremity. First, beginning with the peroneal nerves, I recognize the newer graduates from medical school are using the term fibular nerve, but nonetheless, I'm still using the term peroneal, starting with the common peroneal nerve. As you know, this tracks behind the biceps femoris, which is cut here to show the nerve. One potential entrapment site is when it goes between the fibula and the peroneus longus muscle. Of course, we know that a fracture of the fibula can produce injury. I'm going to show a companion case of stretching injury with a knee dislocation. But for entrapment neuropathy, focus on first. So here's an example. Here is the fibula. And as I start the cine clip, you can see the nerve getting enlarged as it goes underneath the proximal aspect of the peroneus longus. This was a golfer who developed foot drop. There was no trauma. It just, with his activity, this became enlarged and it set up this entrapment neuropathy and his foot drop. Now here's a companion case, not an entrapment neuropathy, but nonetheless, I want to show it for completeness sake. This is a patient who had a knee dislocation. We can see edema here of the common peroneal nerve compared to the tibial nerve. So of course we can't forget to look for that. And here is the tibial nerve with the speckled appearance and the edematous appearance of the common peroneal nerve. And as I start the cine clip, you'll see how enlarged this nerve gets compared to the tibial nerve. Sorry that the arrows are not moving as they did, but nonetheless, you get the idea that this is hypoechoic and thickened compared to the normal fascicular appearance, and here it is in long axis. Again, nerves should stay the same size or arborize and get smaller. They shouldn't get larger and definitely not hypoechoic. Now, somewhat of an entrapment neuropathy, what's more of a compressive neuropathy, has to do with the peroneal intraneural ganglion cyst. This is a really interesting phenomenon, rarely described in other nerves. This by far is the most common nerve that we see this. What will happen is the patient may have a palpable mass at the fibular neck or head region. Now, typically when a patient develops foot drop, many times it's assumed clinically that it is just incidental. And we see this with patients who cross their legs, maybe with trauma, or with weight loss because they're more likely to compress the nerve externally. But one must realize that almost up to 20% of those patients with foot drop, this is due to an intraneural ganglion cyst. Now, what is interesting, unlike the idiopathic variety with people with weight loss, we see this with patients with a high body mass index. And let me explain why this relates to the intraneural ganglion cyst. So first of all, we know that the tibiofibular joint connects to the knee joint in about 20% of the population. And what has been shown that if you have a high BMI, you're more likely to have osteoarthritis or cartilage problems. Therefore, you're more likely to have a joint effusion. And with a high BMI, you're more likely to have that joint effusion under pressure. And if you're one of those 20% where that knee joint connects to the proximal tibiofibular joint, that joint will be pushed into this joint. And if that happens chronically, what will happen in some people is that fluid will be pushed into the articular branch of the deep branch, and then this fluid can track into the common peroneal nerve. Basically, that's the pathophysiology of a peroneal intraneural ganglion cyst. It's been shown that if you inject contrast into the knee joint, not necessarily the tibiofibular joint, knee joint, it can actually connect into this ganglion cyst. And like all ganglion cysts all over the body, it's a multilocular hypoechoic to anechoic collection of fluid connecting to a joint somehow. This one is connecting via a nerve. We talked about the paralabral cyst, where that ganglion type cyst connects to the shoulder joint, glenohumeral joint, through labral detachment or tear. So back to this. By MRI, this can be challenging. It's been called the signet ring sign, where you see a small ganglion cyst next to the common peroneal nerve. Here it is tracking along the articular branch. Now, why this is challenging on MRI, first of all, if the history says pain, this almost looks like one of these veins in the subcutaneous fat. Hopefully, the history will guide you to the problem because it can be subtle when they're small. Here on the ultrasound, the typical appearance of a ganglion cyst, multilocular, hypoechoic or anechoic, we see it tracking along the fibular neck and tracking along the common peroneal nerve. Now here's a companion case. This is an extended field of view. These are 1 centimeter markers here. This thing was over 15 centimeters going into the sciatic nerve. So what we see here is this multilocular fluid collection. And I'm showing here now the effect of that, the fatty infiltration and edema of the common or the extensor muscles of the leg. And here we see denervation edema on the MRI. So these can be quite enlarged. Continuing now to the superficial peroneal nerve. Now this site is prone for entrapment, where it pierces the crural fascia of the leg approximately 9 centimeters up from the fibula. And that is the typical site. And what we'll look for, just like any entrapment neuropathy, edema and enlargement. So here's a case where I was scanning this young lady's ankle and the history was pain. I went through my entire ankle protocol, looking at the tendons and ligaments and joint, etc., and everything was completely normal. And what I typically do, especially in the ankle and the foot, and the wrist and the hand, when I'm scanning someone with ultrasound, I'll ask them to point where, with one finger, where the problem is, or explain what's going on. And what she said was that I have pain and numbness shooting down my leg. So, of course, when you hear that history, you think this is a nerve problem. And I said, please explain more. And she said, whenever I am exercising, or she was actually a ballet dancer, this would create the problem. So I asked her to reproduce the symptoms. And what I saw here was the superficial branch of the peroneal nerve showing enlargement as it comes out under the fascia. And at the site, there was a muscle hernia. So this was a muscle hernia creating this this entrapment at the entrapment site. So the resolution of ultrasound showed the nerve problem and the interaction with the patient, of course. And the dynamic imaging brought out the muscle hernia, which was really contributing, or I would say causing, the nerve entrapment at its entrapment site. And we know muscle hernias occur in the lower extremity, most commonly the tibialis anterior, where you have penetrating vessels, which is weakening the fascia. All right, moving on to the tibial nerve. The tibial nerve, remember, it's not the posterior tibial nerve. That's an incorrect term. There's only one tibial nerve. And here it comes down here, and it has different ways it can bifurcate and arborize. It gives off a medial calcaneal branch, which is sensory in the subcutaneous fat of the heel. Then you have the two larger branches, the medial and lateral planar nerves. Sometimes all three come off at the same time as a bifurcation. And then you have the inferior calcaneal nerve, some people call it Baxter's nerve, which is the first branch off of the lateral plantar nerve. This one is really difficult to identify on ultrasound. These two are easy. This one you can typically see. Now, because this is an enclosed space, this is where we're prone to entrapment. By far, the most common cause of entrapment is a ganglion cyst. You can have other causes, masses, etc., but it's really that is the problem. Now, a side point I want to make. If you consider all the entrapment neuropathies that I've talked about so far in both extremities, the one entrapment that creates the most dramatic nerve enlargement is cubital tunnel syndrome. On the other end of the spectrum, the one where I've not yet to date seen enlargement of the tibial nerve is the tarsal tunnel. And this can be explained by the pathophysiology of the edema. Remember, the edema is due to what's called axonal damming. So it turns out the enlargement edema is proportional or inversely proportional to the size of the entrapment space. So the cubital tunnel is a very narrow space. That's why the ulnar nerve is dramatically enlarged. The tarsal tunnel is one of the largest spaces that the nerves pass through. So that's why we do not see enlargement. And I've actually not seen edema on MRI as well, in spite of a clinical finding and even a ganglion cyst pushing on the nerve. There's just so much space there that we don't see the dramatic features of edema and enlargement like the other nerves. Carpal tunnel syndrome is another one, not as striking as cubital tunnel, but definitely in this area in tarsal tunnel, don't expect the nerve to look abnormal. You really want to look for the cause of the entrapment. Another point, when you're scanning, don't just scan in this area because you can have problems more distally. I'm going to show a case of a ganglion cyst from the anterior subtalar joint that was presenting as tarsal tunnel syndrome, and the problem is actually beyond the tarsal tunnel. So first of all, normal. Here showing the trifurcation of the tibial nerve. We're showing the medial calcaneal branch and then the lateral and medial plantar nerve, which is the arborization of the tibial nerve. Here, taken from the literature, showing the inferior calcaneal nerve, here between the abductor hallucis and the quadratus plantae. Now, even with MR, I still have not seen an abnormality of this nerve. What I do rely on with ultrasound and MRI is the end organ of this nerve. What we're looking for here is basically edema and fatty atrophy of the abductor digiti quinti. Now, remember, there are different levels of entrapment of the inferior calcaneal nerve. Actually, the more common one is going to be a plantar aponeurosis and thesophyte spur, where the nerve tracks under that. We can't see that with ultrasound anyways. So just be aware that this nerve is hard to see, and that's why when I'm looking at the tarsal tunnel region and anywhere immediately for nerve symptom, look at the abductor digiti quinti for fatty infiltration or edema as a clue to some kind of entrapment more proximally. I already mentioned this. Ganglion cyst is by far the most common, rarely these other items. And I just talked about this at length. The tibial nerve is usually relatively normal. Here is a large soft tissue ganglion cyst. Again, ganglion cysts all over the body have the same pathophysiology and they look the same. The pathophysiology is joint fluid, most commonly coming through a defect in the capsule of the joint, and you have fluid pushing it out into the soft tissues, forming a multilocular hypoanechoic collection. Here with through transmission, the fluid can be very viscous, like these little dots shown here. And here the tibial nerve is being displaced, although the tibial nerve is otherwise normal in size and echogenicity. Now here is that companion case where the tarsal tunnel region was completely normal. But as I scanned more distally, I saw that the medial plantar nerve was displaced by this soft tissue ganglion disc coming from the anterior subtalar joint. Here, the middle facet of the anterior subtalar joint. And the nerve was irritated. You push on the transducer, and the patient, yes, you're eliciting the symptoms. So you get that feedback telling us that we're in the correct area. Now, here's a rare example of soft tissue varices creating tarsal tunnel syndrome. Now, I don't know how many vessels should be considered abnormal. I haven't seen that literature either. I basically compared to the other side, and this was like I saw 10 different vessels compared to 2. So I know it was asymmetric and the patient had tarsal tunnel syndrome. So this was a suggestion of the cause. There was no other cause for it, so we presume that. So I'm just saying this is a subjective finding. I would compare to the other side. Okay, finally, in the next 4.5 minutes, I'm going to cover common plantar digital nerve. So first, the anatomy. Now, this is very important as we sort through how to image interdigital neuromas. The key here is this transverse metatarsal ligament connecting the plantar. The bursa, the intermetatarsal bursa, is dorsal to that between the metatarsal heads, where the neurovascular structures are plantar. They're in different locations, these two things, because of this transverse metatarsal ligament. So that's why I scan plantar. So interdigital nerves, neuromas, this is really an entrapment, the common plantar digital nerve branches. Edema, fibrosis, and necrosis, third more than second interspaces. Females and wearing high heels, someone with more pliable foot, whatever that means, narrow toe box shoes will do it. They can be asymptomatic in up to a third, and especially if they're under 5 millimeters, measuring medial to lateral. Now, what's interesting, people use the term Martin neuroma freely and actually many times incorrectly. I know because I had done that for a long time. I now am corrected where the only neuroma that is a Martin neuroma is the third interspace. The other ones have other names. So what I've learned through the years is I never want to use an eponym ever again. That way I know I won't use it incorrectly. You can use them, but I think it's kind of whatever. I just call them interdigital neuromas and indicate the web space. Okay, so scanning from a plantar aspect. I again want to highlight the location of a bursa versus a neuroma. In white here, we have the transverse metatarsal ligament. We know that the intermetatarsal bursa is dorsal between the metatarsal heads. The pathophysiology is that the plantar digital nerve, when it courses over the edge of this transverse metatarsal ligament, that's where the neuroma forms. Therefore, the neuroma will be more distal and more plantar at the edge of this ligament. So here on MRI and ultrasound, we can see the neuroma. A dumbbell appearance, it's plantar. Remember, more dorsal is going to be the bursa. They're different locations. Here, it's hard to tell the difference. I'll explain how we can, but this is the neuroma and this is the bursa. And what's interesting, that's not interesting, when I'm in, well, it could be, when I'm interpreting MR, I really rely on this, now I really rely on this long axis view of the metatarsals. Knowing that the pathophysiology, the neuroma goes beyond the transverse metatarsal ligament. A bursa usually will not extend that far. So unless it's dramatically enlarged. So this, not only this pedunculated appearance going plantar, I really rely on it going distal as well. All right, let's get to the ultrasound. Now, when I'm scanning from a planar approach, here is the edema of the nerve coming over the top of the transverse metatarsal ligament. Note that the bursa is more anechoic and it's dorsal to the ligament. Nerve, as it comes over the edge of the ligament, forms a neuroma. So the neuroma is more distal and more plantar. So they look different. Also, when you perform the ultrasound, the bursa is often compressible, and this is minimally, if at all, compressible. All right, 3 steps how I perform this ultrasound. I always have my finger on the other side, playing the metatarsals apart and applying pressure. And the normal interdigital space will be low-level echoes like this, fibrofatty tissue. Here's the abnormal situation, hypoechoic mass-like area. And what's important is when you're scanning this transverse to the metatarsals, that you scan distally as well, staying perpendicular to the metatarsal heads and going distally. Again, that's where the neuroma lives. Of the 3 steps, this one is the least accurate. I then go to step 2, looking long axis. And that's where I want to show exactly what I mentioned. Then the neuroma is going over the edge of the ligament. The bursa is more proximal and dorsal and more anechoic with through transmission in most scenarios. Here is on MRI. There's the neuroma, there's the bursa. They are different locations and they look differently. Here's a companion case. Here's the transverse metatarsal ligament, the neuroma, the nerve going into it, and here's the bursa. And again, this is there's minimal fluid. This is not even considered bursitis based on the size, at least, because you're allowed up to 3 millimeters in medial lateral to be considered normal. And finally, step 3, the most important, the Mulder maneuver. This is a clinical sign that if you squeeze the foot from side to side, that there'll be a painful click of the neuroma moving in a planar direction. Here's what we're looking at. There's the neuroma. This is normal. As we squeeze from side to side, what we're seeing is plantar displacement of the neuroma. That's why I scan plantar. I'm looking for 3 things. 1, do you see the neuroma moving? 2, do you feel the click? And 3, are you reproducing the symptoms? If you have all 3, you're 100% accurate. But look how better we can see this neuroma, and we can measure it more accurately. The bursa will not do this. Why? Because it's held in a dorsal location by the transverse metatarsal ligament. So again, the anatomy is key to understanding the difference between a neuroma and a bursa. Finally, last slide before the summary here. Remember, pericapsular fibrosis related to plantar plate injury. It can simulate, especially in MR, perhaps a neuroma, although we wouldn't fall into that pitfall. We can see that the capsule here is missing. It's edematous, it's torn compared to here, where it merges with the plantar plate. And by ultrasound, it's really hugging the metatarsal joint and not in between. Importantly, you would not have a positive Mulder's maneuver with pericapsular fibrosis. Take-home points. Entrapment. They occur at specific areas, the hallmark, edema, and enlargement at and proximal to the entrapment site. Next thing, when you push on the edematous nerve, they will tell you you're in the right location, reproducing symptoms. This complements electrodiagnostic testing. I've highlighted the use of dynamic imaging, looking at snapping ulnar nerve, snapping tricep syndrome, also the Mulder maneuver in the foot as well. And the final point, although I'm highlighting the locations of entrapment neuropathy, you should scan the entire nerve in the extremity. In short axis, it takes a minute to do. It is so easy. The reason is, although clinically it may be suspected someone has an entrapment neuropathy, you could have a nerve sheath tumor or something at other locations. So you may start at an entrapment site, but you should scan the entire nerve to cover everything between the entrapment sites in short axis. That can be done very efficiently. Again, with this QR code gets you to where my syllabus material is. There's other educational material, usually ultrasound things. You can consider looking to that if you wish. I want to thank you very much for your attention, and now I can take some questions.
Yes, thank you so much, Dr. Jacobson. At this time, we will open the floor for any questions from our audience, and you may submit your questions through the Q&A feature.
The first one is share the PDF. Hopefully you got that QR code. Um, I can put the slide one more time if you like. I'll see if there's any other questions that pop up in the meantime. Okay. Well, I'm not seeing any questions. That's either a good sign or a bad sign. I'll
You
presume
are
it's a good sign.
so thorough that everyone's like, yeah, I
So
understand.
on my website is my email. You can email me any questions and I can answer anything offline, not offline, but outside of this webinar. Okay?
Well, awesome. Thank you so much again for sharing your lecture with us, Dr. Jacobson. Oh, a question did just pop in into the Q&A if you got.
Oh, I almost got out of it. Okay. Which peripheral nerve entrapment is most difficult to diagnose? And I think anterior interosseous nerve is by far the most because the nerve is small and the muscle is so echogenic from the effect of that I can't penetrate through it. That by far is the most difficult. The easiest would be the one where the nerves are most enlarged, would be number one cubital tunnel, number two carpal tunnel. I think tarsal tunnel is challenging because the nerve looks normal, but you just have to keep looking all around for a ganglion cyst or some other cause. Those are the ones that really come to mind. The interdigital neuroma is challenging, but that's why I feel that Molnar maneuver really helps save the day on that one. So that's just some information on my feeling on the most difficult nerves to scan for entrapment.
All right. Well, thank you
All
so much,
right.
Dr. Jacobson. And thank you to everyone for participating in our noon conference and asking uh, two questions. Thank you so much. You can
Thanks.
access the recording of today's conference and all our previous noon conferences by creating a free account. We'll also email out a link to the replay later today. Be sure to join us on Thursday, April 3rd at 12 p.m. Eastern, where Dr. Mark Gosselin will deliver a lecture entitled Conceptual Approach to the Pleura. You can register for it at mrionline.com and follow us on social media for updates on future noon conferences. Thanks again and have a great day.